Just get my slides up. Oh, is it just... So I'm going to argue that I think two-drug regimens really merit serious consideration at the moment. I think that there is a wave of treatment optimization that's looking at this. And I just want to argue why I think it actually is Africa that needs to be pushing this agenda. So these are my disclosures. So we talk about many combinations. Now, everyone's talking about dolutegravir 3TC as the combination, and Michael headed the Gemini studies, and that's certainly what's on everyone's agenda. But there are lots of two-drug studies that have been done, both switch studies where people are virologically suppressed and they move to a two-drug regimen, and the more testing area, which is in naive patients with high viral loads. Michelle at one point said, oh, there are all these two-drug studies that have failed. There are plenty of three-drug studies that have failed, 4 drugs, 5 drugs, 1 drugs. It's not just two-drug studies. It's not about the number of drugs. It's about the potency of the combination. And I'm going to argue again that when we're looking at this, our understandings of resistance has evolved in such a way that we don't have to go into, we have to have 3 drugs, which is a real article of faith. It's also important to understand that when you do switch studies, especially, and that's the vast majority of people in Africa, are virologically suppressed on their ARVs and happy, that we are talking about moving patients already virologically suppressed across. And it's not difficult to do that. Most patients who are suppressed will remain suppressed. You don't need the same drug potency to keep them there. But I'm also going to show you that it actually doesn't matter, that when we have potent drugs in 2 regimens, that works very, very well. A lot of the real-world situations are, again, historical articles of faith. This obsession with tuberculosis and with high viral loads is slowly and steadily becoming less and less. If you use your IPT and if you do decent TB screening, you can actually get rid of most TB problems that start. As our PEPFAR programs are improving in many of our countries, the average CD4 count is going up. In South Africa, certainly, we've dropped from about 25% of patients having TB at baseline to about 7 or 8%. So we're tailoring regimens around a very small proportion of patients rather than about the more than 90% of people who need a safer and better regimen. The other real-world thing is people are coming back into therapy. The idea of a truly naive patient, certainly in the South African situation where we are, and I think probably almost certainly for most countries in the sub-Saharan region, is most people who are initiating first-line antiretrovirals are actually coming back, not starting from scratch like they were maybe 5 or 6 years ago. And this, as I said, this article of faith, we started out with one drug, then we went to 2 drugs, then we went to 3 drugs, and then we thought, well, 3, 4, 5, 7 must be better. And we went up there, and then suddenly all the patients' livers exploded, and they started vomiting. We came back to 3. And then we went to 2, and there were a few failures, so we think 3 is that magic number. And as I said, the view of drugs like 3TC as weak drugs has been strongly discredited when we look at the resistance data. So we have randomized control studies which demonstrate that initiating 2 drugs therapy, specifically dolutegravir 3TC at this stage, and several other drugs, RCT level evidence that it works in naive patients. There are a few caveats on the edges, but for the majority of patients, they will respond, and they will respond really well. And I don't quite understand why the gold standard, which did not apply to many regimens we used in Africa, including tenofovir 3TC and efavirenz and D4T combinations, are not now being applied in the same way using a superior level of evidence. So these are the recommendations from rich countries where they really are tentative about 2-drug therapies. And again, it does not make complete sense to me. The argument that we haven't got enough real-world data I'd like to know, in terms of virological outcomes, which regimen that did really well in the clinical trial did really badly in real-world outcomes. I'm not talking about the pregnancy issues and that stuff. We don't need real-world. We just need the data. So to argue that 2-drug regimens need to be tested in the field before we take them on, I don't think it stands up to the test of time and the various regimens that have come through here. So obviously, if you have 2 drugs, you lose whatever drug you lose. Out of the 3 drugs that you were going to give, you would have lower toxicity. And particularly for Africa, if we could get rid of tenofovir, it would be great not to have to worry about the creatinine, which is a major programmatic complexity. And in all honesty, is not being rolled out anywhere really across the region. And where it is being rolled out, very few people pay attention to it. So I did some back of the envelope, I went on calculator on my computer and worked out that if if you can get rid of tenofovir, it's 1 kilogram of chemicals every 10 years that your kidneys are not going to have to process. So I used washing powder because I thought it was more emotive than anything else. And if you don't have to put that through your body, why would you want to? So getting rid of the third drug just simply because it's a nice to have doesn't make complete sense to me. You also get smaller packaging, you get smaller tablets. These things are not terribly important to us, but for program planners, you have to have these things stuck up in the pharmacy, and for patients who have to take these tablets home, this is quite a big deal. I'm going to talk about the injections because I think this might change the game over the next 3 to 4 years, including in Africa. And one of the things that amazes me about the injections is how much our patients love them. So these dual therapy injectable studies, currently there are many of these studies happening. The combination that's been looked at in the most detail at the moment is cabotegravir with rilpivirine. This is an amazing study. They had these patients on the injectable, then they moved them to the oral formulations, and then they said to these patients, they said, would you prefer the oral, would you prefer the injections? And like 90% of the patients said, I want the injections. I don't want these oral tablets. And for me, that's amazing, is that patients really are finding the fact that you don't have to remember every day, that it's programmatically much simpler, that actually injectables are really good. And in the next study, that they asked patients, like, what would you like to have in your treatment option? And I've seen other similar studies coming out of Africa, is people overwhelmingly want injectables as opposed to the interesting thing about the dual therapy studies, these injections are actually quite sore. The major side effect was tenderness, and it's 2 injections every 2 months. It really amazes me that patients would rather than have that, than they would overwhelmingly would rather have that than an oral drug. The next thing is obviously cost. If you lose one drug, whatever that drug is, you obviously lose the API, you lose the manufacturing cost, and there's a significant packaging cost reduction as well. So what are the counter-arguments? High viral load. The vast majority of our patients don't actually have high viral loads. They are either switch patients, and most of our patients are sitting on stable therapy. They could be moved to 2-drug therapy. Hepatitis B is often raised as an issue, and I think it is an issue, but to be honest with you, it's a bit of an article of faith that there are all these terrible hepatitic reactions when you withdraw the tenofovir. We haven't actually seen that. There is the tenofovir is the drug of choice in hepatitis B, but we've got tests to get rid of that. And certainly in places which have hepatitis B vaccination programs, that is steadily becoming less of an issue. As I said, TB is actually a tiny number of patients. I did the back of the envelope calculation for South Africa, and of our 5-6 million people on ARVs, only about 30,000-40,000 people have TB. So they're a very small proportion of the overall ARV population. And we have really good drugs for them. We have efavirenz-based regimens which work like a bomb. So I don't understand why TB is the reason not to roll out dual therapy or any other regimen for that matter. The data that we have in terms of pregnancy and viral load decay around the integrase inhibitors I think is pretty good, and with many of the other drugs as well. And people, like I said, Michelle was saying there's lack of evidence. Well, a lot of the regimens we've put into the public health programs over the last 20 years have had a lot less evidence than we have now for some of these dual therapy regimens. So my conclusion is that I think that 2 drugs are looking quite rosy at the moment, and I think we need to be applying our head. I think initially as a switch strategy for patients who are healthy and well, from both a cost and efficacy perspective, it's something we should be thinking about. And I think that we need to be thinking very hard before dismissing the idea of the injectables. I think our patients are going ahead of us and are going to be demanding these drugs very, very soon. And we need to be thinking about how we could get them the drugs rather than thinking about the fact of why they shouldn't have them until we have masses and masses of programmatic evidence. Thank you very much.